Welcome back, everybody. So good to be with you. I hope you enjoyed the first part of this year's Health Summit, which obviously this is the inaugural one, and we only hope that it's just going to get bigger and bigger and become a part of your diary going forward every single year. So welcome to the SA Healthcare Summit that's been brought to you by AfroCentric Group. Now, in the first session, we focused on COVID-19, which we know has firmly placed the spotlight on the strength and weaknesses of our healthcare system. We now delve into other factors that impact our healthcare system and how these can be addressed. Remember, this is an interactive session and we want to hear from you. Send us your comments, send us your questions. We're going to hear from some experts now. Then we'll have a sit-down conversation with all of them and we'll throw out some of the questions that you've been asking and some of the issues that came up during the conversations. Now, our next speaker. One of the fundamental tenets of healthcare is access. And today, Dr. Samukeliso Dube joins us to look at the question of access and the broadening thereof in the context of primary healthcare. Dr. Dube is currently a general manager at AfroCentric Health, where she heads up health policy and medical advisory functions. She has over 20 years' experience in various roles in the health sector as a practicing clinician, researcher in clinical trials, managed care, and in a commercial capacity. Ladies and gentlemen, an absolute pleasure to welcome to this year's summit, Dr. Samukeliso Dube.
Many thanks, and a good morning and a good afternoon to those who may be abroad, and a good evening to everybody. Thank you so much for this opportunity to present and to deliberate on some of the issues that are critical in our country. My task today is to talk about broadening access to healthcare. We all know that health is wealth, and we do say at times wealth is health. But that bidirectional equation does not always balance. So we know that health is fundamental to economies, and the basic building principle of healthcare is actually primary healthcare. My task today is to reflect on how did we get here, why we are here around primary healthcare, and reflect on some of the opportunities that we have for progress, and maybe, conclude by what is success, and looking ahead, what does better look like? We all know that, we can pioneer, we can innovate, we can do more, we can even put men on the moon. But we can do better if we don't leave anybody behind when it comes to healthcare, and if we can close better the inequities that we are seeing in our country around healthcare. So I'm going to start by the basic definition of what primary healthcare is, because as we talk about health today, we know that the basic building block of healthcare is actually primary healthcare. Now, ladies and gentlemen, there has been a definition of primary healthcare that actually transcends most of us here, and that is around from WHO and from UNICEF, but that actually started in Alma Ata in 1978. And I'm going to just reflect on the important parts of that definition, which says that it's health that aims to ensure a highest possible level of health and well-being and equitable distribution. And this focuses on people's needs and as early as possible along the continuum from health promotion, disease prevention to treatment, rehabilitation, and palliative care. And this is as close as possible to people's everyday environment. So that means that this healthcare environment that we want to advance is more than what we are seeing in the healthcare sector, and it goes to the social determinants of health. And now, one of the timelines that I love to actually display is where we're coming from. We started in 1978, where the world declared what primary healthcare should look like in Alma Ata. And in there, we know that in 2008, there was the Ouagadougou Partnership that spelled out what Africa should do with an operational framework of what primary healthcare should look like. In 2010, the South African government made an initiative to actually motion re-engineering of healthcare. And with that, we know that we did accelerate in our journey around the NHI. And in 2018, the world actually gathered again in the Astana Declaration, where, again, we're to revive, what primary healthcare should be 40 years after Alma Ata. Where we are right now, we are seeing that COVID-19 has actually dealt with us a blow that says, revisit what your healthcare should look like. In the fragile settings, you need more resilience, you need to build more capacity for you to actually have better around primary healthcare. And indeed, where we are in South Africa, we are stuck in these inequalities that we are seeing that actually were brought to the fore by COVID-19. And indeed, this provides us with a window of opportunity to act better. Shall we reflect, ladies and gentlemen, to what primary healthcare is and what is not? And one of the issues that we're talking about is meeting people's health needs. You meet them, but it's about broadening access. Primary health care addresses broader determinants of health, so it's not enough to give a pill and a syrup. It's actually more than that, working into the determinants of health. And lastly, it's about empowering people to take charge of their own health. And with this, we all know and we should take note of what primary health care is not. Primary health care is not gatekeeping. It is not about gatekeeping. It is not about rudimentary basic care. And there is another misnomer about it should just promote and prevent and just do rehabilitation, because it is more than that. And indeed, we know that it is not first contact care, because at times, when you get injured, when you are involved in an accident, your first port of call is emergency care. Primary health care is providing the right package of health at the right place, at the right time, and it is not about low quality care that is only reserved for the poor. Why now? Why should we act, ladies and gentlemen? We are acting in healthcare broadly because we are seeing the demographic shifts. And we submit, what we are seeing from the world over, that the demographic shifts that are happening, particularly in Africa, are about how we are going to win in the demographic dividend story. We know right now we're in the midst of a population census, and we have seen how our population pyramid is. Many youth again, we've got a growing gray in our population. So we are certainly in that demographic transition. But with it, we are also seeing that there are some epidemiological shifts. What does that mean? It means that the disease profiles, and I'm going to present later about this burden of disease that we are seeing in South Africa, the disease profiles are changing. We are seeing, again, a changing burden of disease. Emergencies, we all need to plan for that, and we talk about resilience. And when you talk about resilience, you're talking about how we plan for future emergencies. And lastly, we are riddled in South Africa with a burden of non-communicable diseases, including oncology, including mental health, and we need to address that, which is why then the topic of primary healthcare becomes important. We are also seeing a shift in the healthcare consumer of today. That healthcare consumer, what they want, they've got a high expectation of what they want from our health system. But that system is lacking in performance. There is a quest for self-reliance. I want to make sure I go to Google, understand what I'm suffering from, and request solutions from online. And even if I can, phone my doctor and they provide solutions for me whilst I'm at home. That's the trend that we are seeing in our healthcare consumer. And indeed, this consumer actually is looking for value. This consumer is looking for outcome measures that they can track over time to see that they benefited from the system that we create. And ladies and gentlemen, we are not short of new therapies and technologies that are emerging in our economy, in the country, in Africa, but we know we need to be pioneers better of what is relevant and what works in this healthcare economy. We cannot, this will not be complete without us knowing that why now is because there is a window of opportunity from COVID-19 for all of us to act. And within that window of opportunity, we know fully well that if we don't fix primary health care, the results are, it's unnecessary referrals. The results that we see include loss of opportunities to innovate, actually it's missed opportunities for us to innovate. And indeed, in the health economy, we are finding many people being frustrated by the services that we fail to produce, or even the whole organization of care, especially when, as I referred to earlier, when we are seeing primary health care as just gatekeeping and not an opportunity to expand access. Now, again, when you go to literature, you will see that there are many other events that are happening. Literature is showing us that people are living longer in many areas of the world. And indeed, even in South Africa, life expectancy has been rising, which is good news. And as that rises, we need to prepare for when people are growing old or they're growing gray. But because their later years, they would live in poor health. That is an opportunity for us to innovate in primary health care. And also, there is projected change in the percentage of disease burden, and indeed, this is important because what it does is that the health systems need to be nimble enough to provide us with that capacity to innovate. The quadruple burden of disease, I've spoken about it. This is what we have in South Africa. And I want to just point to us that when we are looking at data in South Africa, we are all much healthier than we were 20 years ago, but mentally, we are falling apart. The World Health Organization now estimates that 1 out of 5 people on the planet is clinically depressed. What that means is that there is a rising burden of mental health that needs to be addressed in many ways than one, and primary health care will help us in that particular burden. I put here and I advance that the infectious disease burden that still exists in our country, for example, tuberculosis, which is often fueled by HIV, is still top of the list, but there you can see stuck in our eyes is the issue of non-communicable diseases. Yet, the delivery model that we have today for primary health care is constrained and it is conflicted. There is need for us to innovate in the primary health care economy in many ways than one. I admit and I submit in this particular presentation that these constraints and variables we all are familiar with. For example, the health spend that we have versus the GDP. For example, the consumer who demands value. For example, new technologies and innovations as I've alluded to earlier. But I want to point again to the changing health practitioner. The changing health practitioner who requires more for their people, where they come from. The changing healthcare practitioner who is aspirational in nature and wants to embrace these new technologies. Where do they fit in that primary healthcare spectrum? And this is what we need and we ought to innovate for. In that trend, again, we've got a variable of digital health that is rising and what we want to innovate around. And this is, again, why there is need for primary healthcare delivery model to deliver on these particular variables. South Africa has got large expenditure disparities between public and private sector, and where we actually meet, there is a missing middle that we all need to come together as a country and co-create solutions for those who are the missing middle, as we all often call it. In this fragmented healthcare delivery model, often in the public health sector, we know what is needed in the healthcare referral pattern. That moves from primary healthcare to quaternary care, as we call it, but we find that that is more fragmented in the public health, in the private health sector, and we ought to innovate a service delivery model for primary health care that actually delivers better and more for the people. Now, ladies and gentlemen, where are those opportunities for progress? What is it that we could leverage and from the challenges that we have to gain and have better momentum and create opportunities for the country to actually be positioned better for progress? I submit that we all know and we all are aware of the fragmentation that exists in healthcare today because the care coordination models do not work. We know that we actually need more alternatives to the hospital framework, which the hospital-centric framework that we have that is curative in nature. We also know that financing for health and financing for development is top of our agenda. And then we know that as we co-create this agenda for progress, we ought to come up with solutions on how else we can fund healthcare. And this is both in the public and in the private sector. In fact, this is about the healthcare economy of a country. Financing healthcare in general, we know that we need to advance pro-health taxes, public-private partnerships, and in medical schemes, we know that we could finance healthcare better by making available even low-cost insurance models and also contracting on outcomes more than just contracting on a fee-for-service model, and the value chain integration that actually would help our clients, our members, and our patients to get more for their money. I think this is an important presentation, ladies and and gentlemen, because if we don't pursue alternative financing models, we know that the health pace is not enough for what we want to achieve in the healthcare space. For primary health care, there is need for us to strengthen governance and accountability mechanisms. This is espoused in the National Health Insurance Framework, and this would start at a provincial department level. This is needed in the medical scheme environment, and this is needed in the hospital environment so that there is transparency on how we can actually contract better. Accountability hinges on the availability of accurate and relevant information that will help us to track performance over time and across providers. Recently, we've been talking about outcome-based measurement frameworks for South Africa, the OMRO for South Africa. I believe that would be the glue for that accountability and transparency. Indeed, in the changing nature of the healthcare professional teams, the multidisciplinary and multi-professional team framework that we are wanting to advance, at least in the private sector, is also needed in the public sector, because that makes it possible for us to deal with some of the disease burden issues that we have spoken about earlier. Indeed, because when you're talking about oncology, you need many teams to rally around that patient for better care coordination and for better case management. And lastly, I know that we need regulation on both the supply and the demand side of healthcare. As has been clearly articulated in the HMI report, we need the Council for Medical Schemes to innovate better and regulate on the demand side, and many other institutions like SAPRA, like the Health Professions Council, to also innovate on the supply side of healthcare, so that these frameworks that we are putting across can better be executed. I want to conclude in my discussion about what better looks like. A glimpse into the future that we want. Ladies and gentlemen, the future that we want, the future that we are espousing to, is a future where we can move away from dysfunctional gatekeeping, a future where we can move from fragmentation and from inequities and fragility. That future requires an ambitious shift that strengthens the range and quality of services that people can obtain at their local health facilities. I want to trust that my healthcare facility will give me what I need at a primary healthcare, in a primary healthcare fashion. And also, when we're moving from fragmentation, we want that it's a people-centered integration, it's people-centered progress or programming that will help us to make sure that it's not impersonal, because once it lacks that human touch, people see it as impersonal. And indeed, the inequities that are stuck in the Gini coefficient, which actually shows us in South Africa that inequalities and inequities of the past, they need to be redressed in a way that the health system demands and produces fairness and accountability. And lastly, from fragility to resilience. When we are saying we don't want a dysfunctional and gatekeeping primary healthcare mechanism, what does that look like? It's a system that is based on value. It's a system that is powered by analytics. It's a system that is member or patient-centric. It's a system that integrates all the offerings. For example, today, if you were to go for your annual screening, where do you go? You book so many doctors, you go to many areas for you to actually just get your annual preventative and screening benefit. And I think that an integrated module would actually help us to get there. This will not be achieved if we are not in strong partnerships. And this partnership is about public sector, private sector, and indeed to partner with non-traditional partners in the healthcare space who would bring in fresh ideas, a fresh perspective for us to innovate better. Better looks like the care continuum, which is home to hospital, hospital to home, home and within the community, espousing the values that we see for primary health care. This is about enhancing your journey as a member, enhancing your journey as a patient with the latest technology that is affordable, that is accessible, and it actually meets the need that you have at any given time. And it should focus on wellness. In fact, some people do relate that we know that for us to have a healthier nation, it needs to be a nation that is well, and that when you wake up every morning, you know what you're supposed to eat, how you exercise, even the number of hours that you sleep. So we want to enhance that in an integrated fashion so that we can have a healthy nation. in a society where there is no more fragmented care, we know that we need to bring in at least two dynamics in terms of chronic disease management and acute care. This is about wellness, it's about how we screen people better, it's about diagnosis in primary health care, and care pathways that relate to the clinical visions that, many of the doctors here, they understand, making sure that it has got monitoring throughout, and you can escalate where it's needed, and you can refer higher where this is needed. But there are building blocks for this defragmented care. When we are building towards a coordinated fashion, in an integrated fashion, we need to have health technology infrastructure that works. Earlier on, you heard from Ridwan about the framework, the healthcare economy that needs to rely on a health technology infrastructure that works. And in there is wellness and global beneficiary population screening and health assessment modules that are needed for us as a country. We need to actually do task shifting and task sharing, where tasks that were meant to be done by specialists, if they can be done by other people, not only do we expand and increase and improve the healthcare economy, but we actually say the right care at the right place by the right person at the right price. Another pillar to this building block is to make sure that there is a family practitioner, a GP who actually speaks to the needs of a community and a population in an integrated fashion. They are able to do that. Medicines and in formulary management, we also need to have that as a building block. And lastly, it's appropriate care escalation. When do you refer and when do you escalate? We know, I related earlier to the pyramid that says in the middle there we've got people who are the missing middle. At AfroCentric, what we have done is we have initiatives that speak to that missing middle. And in here, through some of our sister organizations like Fast Pulse, we've moved a program and a care framework that has got a GP, dentist, optometrist, pharmacy network, and allows these patients or members who are in this missing middle to also access hospitals. And in here, for me, I'm seeing this as innovation that says, at what price can you get these variables of health care so that it's available for the family, so that it's available for the member at the right price? And we are saying for us to deliver on the world stage in 2030, Sustainable Development Goals, where we are saying no one is left behind, we need to innovate better. You cannot innovate by leaving the majority of the citizens and population behind. So we are trying to make sure that we integrate this model and get more people to access care in an efficient fashion at an affordable price, and this would be quality care. Ladies and gentlemen, what we have seen in the last 2 years around COVID-19 calls for action. And this action is, what is it that we need to do to build more resilient health system? We know that if we build better, we can have hope. And in this resilient system, what does it look like? A resilient health system is a system that is self-aware. It's a system that understands what it can do and what it cannot do. It's a system that self-regulates, it self-corrects. It's a system that is integrated and is diverse enough, but yet adaptable. If you need to use mobile facilities for you to reach a population, so be it, because you are nimble enough and agile enough to adapt. That is how we are going to broaden access for healthcare. And lastly, for us to move ahead as a country, there are some structural shifts that will be required. The first such shift is regulatory. As I alluded to earlier, the HMI report findings, they do speak about the supply side and demand side regulatory changes that would be needed for us to move in unison to achieve the health for all. We need to look at our financing mechanism. How do we fund healthcare? Because we want to build a system that makes sure that people are not left, penniless after they've funded their own healthcare. We need a reformed health workforce, where doctor incentives, where nurse incentives are aligned with what we want to build as a country. I believe that health as a social sector actually needs to help us build back better as a country if we were to move to the GDP level and GDP growth that we need as a country. And lastly, It's inter and multidisciplinary approaches that we need for each case management. And these are structural shifts that will be required for us to actually move ahead. Ladies and gentlemen, from pearls of eternity, we know that when we are healthy, when we are wealthy, and when we are powerful, things are lovely, but we forget often about our own mortality. I am a scientist, and I know fully well that N, we say N, the number of people who are going to die is 1/1. All of us are going to die. But how we are going to get there and at what age we are going to get there and what state we are going to get there is up to the wealthy and powerful to make decisions about what is the future of healthcare that we want to create as a country. It's only when irreparable cracks set in that we come back to reality. I think COVID-19 has brought us to that reality. It has been a public health emergency that rapidly was overlaid even presented to us economic contraction in a country, and that actually feeds back to the earlier equation I alluded to. Health is equal to wealth, and wealth doesn't necessarily be equal, juxtaposed to health if we do not intentionally build what that health system looks like. And for me, the building block of that healthcare system is primary healthcare. A compelling case right now is being made for South Africa to seize this crisis as an opportunity, as we say we don't want to waste any crisis, and invest better in health, including but not limited to outbreak preparedness, because resilience is about creating that margin, creating more capacity, and that will reap rewards, saving many lives, and ultimately achieving a stronger economic recovery. What does the consumer want? The consumer wants value. The consumer knows what value is. The consumer wants quality, but they want it at the right price. And if we are to deliver that without leaving anybody behind and making sure we can pass the baton stick to the next generation, we would have won as a healthcare sector. I believe that we are healthier together. COVID-19, from the vaccination programs to when you are masked, I am safer, they've brought stark realities to what healthcare should be like. Healthcare is where we say, umuntu ngumuntu ngabantu. This is the spirit of Ubuntu. We are healthier together. I cannot be a healthy citizen when you are not healthy. And with this, ladies and gentlemen, I conclude. Thank you very much.
Amazing. Doctor, thank you very, very much for those words. Dr. Samu really giving us a perspective of where we should be, not where we are, but where we should be as a country when it comes to healthcare, and how to fill the cracks that we have found and the parts where we are wanting when it comes to the medical system here in South Africa. Quality, value, that's what we need. Good, adequate healthcare.